Hi, and welcome to the girls. We're coming to you via Zoom. We're still zooming it in, Janine, and I'm Debbie, if you don't know already. I've been watching the girls show for years and years. I think we're into season 19, Janine. Can you believe we started that long ago?
Yes. And we're still Zoom. I'm getting a little creative with my backgrounds. This is my brand new family room. I don't know many of the people in the pictures, but I thought this was cute for a different show. So we're hopefully wrapping up doing our shows Zoom, but it's been fun. We've been able to reach a lot more people, but I know a lot more people are here watching us online too, because it's the holiday season and we have some people from out of town, right, that are in. So hello to all our family and friends who we haven't seen, but we're seeing you on Zoom. I know everyone's preparing for the holidays. It's going to be bigger and better than ever because last year, of course, was in the pooper. So this year, everyone's over decorating, over celebrating, and I guess overeat.
How could you ever over decorate? Look I have this up all year long. It's the Santa Countdown Nutcracker, because I collect nutcrackers, you know me, with the nutcrackers.
Nutty.
But I count down from the very first day after Christmas, because we're always getting ready for Christmas. Isn't that a great thing that we have something to look forward to?
Yes. You always need something to look forward to. And Christmas is definitely one of those holidays that I over prepare for. And you usually make fun of me for decorating early, but I don't like the cold in Pennsylvania. I don't like putting my decorations up in the cold. So we get it done maybe the first week of November. And if it snows, they might be up until April this year.
Well, I'm all for decorating early because of the same reason. We've been decorating early for years. In fact, we have little white twinkle lights on a lot of our shrubbery all year long. So that's just our landscape lighting. Hey, we have to light it up. We get dark early here. It's like 4:30 and we're dark. So light up the night.
And so this year,
go ahead.
I was going to say this year for our family photo, I bought the kids and us matching pajamas. So that'll be our picture this year.
Well, that's good because everybody's home and probably have pajama bottoms on now with your nice top.
Oh, I do. Always.
So the gift of the year is probably pajamas and casual cozy sweaters and things like that. But, a lot of people are using online shopping. And so, you're going through Facebook and these little ads pop up. I'm sure everybody's seen the ad for the eyebrows.
Yes.
Okay. Now, I think you may have talked about this once before. You did. I don't know which ones you sent for, but I sent for these, and these are the tattoo eyebrows.
Yeah.
They're not too bad. The directions are pretty easy to follow. You get 2 sheets of these, and you cut off a pair of eyebrows. And then you place them because they have them printed on both sides. So the one side is the actual tattoo that you take off and you put that side against your head. Then you put these up. Right, I have them upside down.
They're upside down. Unless you want your wings like this.
2 mustaches. Anyhow, you put them on your forehead. Then you get a very cold water on a washcloth and just keep dabbing until you actually soak this. Then you gently remove it off. So I don't have them on today, but I did do a test on them the other night and they came out pretty good. I mean, if I stood back, they looked really, really great. Then you read the fine print. It's best to do them about 24 hours before you want to wear them because it takes a while for them to set. And then you might want to put powder over them. Well, I think the reason is because I have hair. I have eyebrows.
Right.
I think they work best if you don't have any hair there at all because this was like a tattoo on top of my eyebrows. So it didn't get like really flat and you could see all the gluey spots. So it almost looked like I had glue up here. So I kept trying to press it down and press it down. And before you know it, I just washed them off because it never did set.
Bigger and bigger and bigger and bigger. Like
eyebrows.
How much bigger can these eyebrows get and how much closer to your nose? Because I've tried to put it closer to my nose and I look like an idiot when I put them in that far. So I keep them
see them
now? That's like my natural colored eyebrow.
Wow, the standard way of doing eyebrows is to go from here, and that's where your eyebrows should start, not in here, here equal with your tear duct. So you go up like this, and then you go out like this
Right.
from the corner of your eye. And then in the center where your pupils are, that's where your arch should be. And that's supposed to be most flattering for your face. Some people have that naturally. That's how mine
Yeah, I
are
have a
too.
natural arch in mine.
Some are over pluckers though. Over pluckers or over waxers. And then you have not with
Or
nothing.
some people shave theirs and just like pencil them in.
Yeah,
I don't know how we got on a tangent of eyebrows, but that
well,
is a
I
big
was saying
topic with
about
people now.
shopping online, so I bought these. They're pretty decent, but I don't know if I want to see all the glue on my eyebrows.
I think I'll just stick to the powder. That's what I put on mine because they're
Yeah,
so
I use
light.
powder.
All right, today's show is with Dr. Scott Muir, and he is going to join us to talk about some girly issues, right?
Yeah,
He's
he's used to hearing
gynecologist,
about girlies.
the Lehigh Valley Hospital Network. So we will be right back. You're watching the girls here on SSP TV.
Welcome back to the girls. As promised, we have our special guest with us today, Dr. Scott Muir. He is a specialist OB/GYN. What is OB/GYN? Obstetrics, gynecology, anything to do with women's health. And Doc, you always have some great information for us. I've known you for too many years, I think.
A lot of years, yep.
Yeah, a lot of years.
I've known you both for a lot of years, yeah.
We have some great information that you always pass along through all of your helpful tips that you give us here, not only here, but then when women do come to your office, you have a lot of things for them. But one of the topics tonight is a topic that hits just about every single age group of women. And so you go from teens into adolescence, you have women when they're childbearing years, and then you have the postmenopausal. So let's start off with the topic that you want to talk about tonight is abnormal uterine bleeding. First of all, describe what's normal and abnormal so that our viewers can see.
Yeah, we'll lump it into normal, then everything else needs to be addressed. So normal bleeding for adolescents is, regular predictable menses. Usually you like to see some regularity set in about no later than 16. It can go up to 17, but generally 16. So monthly menses, it always starts off a little rough for everybody until they get regulated. But when they start bleeding in between or they have really heavy prolonged menses, they should see a doctor. As far as the middle age group from adolescence until menopause, that changes. They have, again, regular predictable menses monthly, about 12 menses a year, without bleeding in between and without heavy flow with large clots and bleeding into the clothing. They shouldn't be doing any of that. So regular predictable menses through the average age of menopause, which is 51. And then the last group is menopausal, from 51 on or whenever they quit their periods for a year or more. Then we go on and we start looking into more pathology. We have to be more concerned in the menopausal years.
So when you're talking about having a normal cycle as well, how many days? Everybody's different.
Well, as long as, I always tell patients, one abnormal cycle does not a problem make. But if you're consistently bleeding longer than 8 days, you should get some attention. If you're bleeding in between menses for any reason, really, then you need attention also. The amount of, you can't get really too specific on the amount of flow, but women know what's abnormal. But if you're bleeding into your clothing, you're having difficulty, maintaining good hygiene because of the amount of flow, you should see a doctor.
And what are the statistics on that, Doc? How do people, do most women know right away and come in and get help for it? Or do they think?
Yeah, it's funny because, the statistics are tough because it's hard to quantify when people have abnormal bleeding, how much it is. When they come in, they develop anemia or they develop a change in their lifestyle. They find themselves having to modify the way they live because of how much they bleed. And then, of course, they need to have attention. But, every woman's a little bit different. We've had difficulty in the years quantifying what's too much or what's too little. Generally, as long as you're having at least 3 days of bleeding a month, it's normal. But if you're having consistently longer than 8 days in a row, then you need attention.
Okay. And doctor, when you mentioned about teenagers, when should their first gynecological visit be? Not necessarily an exam, but a visit with you to talk about these things.
They can come in as a teenager, usually for discussions regarding normal cycling, STD counseling, or sexually transmitted disease counseling, and vaccinations. We have vaccinations for HPV or human papillomavirus. The age that you like to see them probably is in, I would say probably 13, 14, 15. in that range. If they have normal menses, they really don't need to be seen until they're around the age of 18 or sexually active. They get their first pap smear at age 21 anymore. It used to be earlier, but now 21 is they should never be really a pap smear earlier than 21. But we get to discuss with them some of their health issues, and any more the sexually transmitted disease questions need to come up way earlier. I really 13 and 14, I think, is a good age.
Wow.
And Doc, when you look at the abnormal bleeding, as a parent of someone who would be a teenager, what are some questions that maybe parents or the guardian should be asking their teen when they're first getting their bleeding, and as that changes throughout the course of when they first start their periods to maybe a couple years later?
Well, we want to see them regulate quickly within about a year to 18 months from the onset of their menses. If it turns out that they are not regular and predictable by that time, you have to pay attention to the reasons for that. Some of it could be health-related issues. We have an obesity epidemic, unfortunately, that can affect how they cycle when they're young. This is usually done by the pediatrician, and then the handoff comes to us as gynecologists if they can't handle it through their pediatrician.
Doctor, how about the other side effects that they get with the menses, the cramps?
Yeah, well,
the pains, the bloating. Some of them have to stay home from school.
It can be awful for some. I agree. It can be awful. It should be handled just with some ibuprofen. Ibuprofen is the drug of choice. Tylenol usually doesn't work very good. If it's handled with ibuprofen, that's fine. If they find themselves gobbling up the ibuprofen, it's really not doing a good job, or they're taking too much of it, then they really need to be seen. There are some conditions that can occur early in their cycling that need to be addressed. I mean, endometriosis is one of them. It's a whole other topic, but ultimately they can have primary dysmenorrhea, which is cramping from the very first time they start having their menses. But in the end, those questions need to be directed to their provider, and they can either reassure them that it's a normal finding, or it could be managed with some over-the-counter medications.
So you mentioned, Doc, about the obesity problem now with teens. Now we know diet, but what about like exercising or water intake? Because I'm always on my kids that drink more water.
Well, I think I don't know why we have the epidemic of obesity, but it does affect women's cycling, and it can put them potentially at risk of health issues later on. I don't have a good reason for it. I think obesity is a whole other topic that needs to be discussed, but it can definitely have a negative impact on the girls in terms of not only cycling, but body image and some other problems. But that's another show.
We have a lot of things that are misunderstood. I hope a lot of the men that are watching this are tuning in and learning a little bit. You as a male, not experiencing what we experience, you have a lot of great compassion for the women. I know that because you've been in it for so long, and you deliver babies, and you see what the women go through. And of course, the guy gets to watch it all, but they really don't have the feeling of it. It's hard to describe to them what it's like.
It can be difficult. Personally, I do my best to try to understand as best I can, but there's certain things I'm just not going to be able to understand. I know I can help a lot of women deal with these problems, and as long as they see me as caring and concerning, hopefully that's enough. I can't. There's no birthing babies. There's no feeling cramps. There's none of this stuff. And your day is disrupted because of your bleeding cycles. But we have solutions here. We have things that can make it go a lot easier. They just have to come in for the appointments to do it.
And Dr. Muir, we said in the beginning of the show how long we've known you, but for our audience who might not know you or recognize you, I don't know how someone would, but if they didn't, just give us a little background about how long you've been doing this.
I came to town in 1994, 27 and a half years ago. I came here, stayed here, went through a bunch of partners in that amount of time, but I stayed on. I live here. I'm part of the community. I like it here. I've grown more attached to the profession over the years as the population, or my patient population, has grown. I'm happy that I can provide service for this many years to this many people. And nobody likes to turn over a physician. You don't want to have a physician come and go over the years and have to have somebody new all the time. So hopefully the fact that I've been here a long time is comforting for many.
Yes, especially you treated my mom, then you treated me, and now you treated my child.
Yep.
So
yeah, generational. I know that. Don't remind me. Oh my gosh, a long time here.
We're dating you a little bit, aren't we?
Okay.
Now I'm gonna catch you off guard. How many babies have you delivered?
That would have been something fun to take care of or to track early on. It's in the thousands. I can't tell you what it is exactly. I'll be honest with you. Dr. Butsinas delivered more than anybody in town. And so she's the record holder by far.
Very
well, I
good.
contributed with 2, but that was a little before your time. And then
Yeah, a little bit.
you
That's
know,
all right. Not that much.
yeah. How
He's
about
got my
multiple
2
births?
though. He's got my 2.
Yes, I did.
Right.
Yes, I did.
How about multiple births? How many multiple births? Like, what was
Well,
the
you know,
biggest amount?
Yeah, well, twins are a big deal. I'll tell you, we only get about maybe 2 or 3 sets of twins a year, so you can do the math on that one. So there's a decent number, but I don't deliver everybody. We have partners that help out in the practice. So it's a fun business. You know, the twins always make it extra special.
Twins.
Yes,
How
we
about
Having
do.
twins
Twins are a
myself
big
and
deal.
Janine, I know we all about this.
Yeah,
It's
you
funny.
do, right? With having
Yes, I
twin
do.
boys.
Yes, I do.
How about triplets, quadruplets? How
I
about
had one.
anything
I
higher?
had one set of triplets. I had to deliver them down in Allentown, but that's when you could do that. You know, I got temporary privileges and was down there for that, which was fun.
Awesome.
All right, let's take a quick break. When we come back again, we're with Dr. Scott Muir. He's OBGYN with LBPG. We'll be right back. You're watching the girls here on SSPT.
Welcome back to the girls. We've been speaking with Dr. Scott Muir about OBGYN and normal and abnormal bleeding for women. Doc, we've touched on the beginning stages of a woman's menses from the early ages on. Now, how about let's talk about the abnormalities and what they can mean from whatever age into maybe older age.
Okay. Let's start with the teenage group. Any teenager that has some abnormal bleeding, it's a possibility of infection. They need to be seen immediately or within a very short amount of time. You have to worry about that because it can affect their long-term fertility. Unfortunately, chlamydia, which is a sexually transmitted disease, is extremely common, especially in this area. They got to get seen. Other reasons are for accidental pregnancy. They could be pregnant. If they pills or whatever, they could be pregnant. And the other is if they just miss pills, they may be bleeding abnormally, but they need to be seen. When you have abnormal bleeding in a teenager, they absolutely positively need to be seen as soon as possible. As they get a little bit older and they get through their childbearing years, you know, when they're done having their kids and maybe they've had their permanent sterilization, bleeding problems after that time become a nuisance. They're done with their kids. They really want to have, it's life 2.0 where they don't have to worry about, extending the family, but now all of a sudden the bleeding problem becomes disruptive to them. That problem needs to be addressed by their physician. We usually have a workup that involves ultrasound and maybe some other lab testing. But once we realize that this is basically benign bleeding, it's just nuisance bleeding that they have, we have wonderful ways to manage this now. Years ago, when you had abnormal bleeding and you were done with your kids, it was the old, you're done with that, let's get rid of that and have a hysterectomy. But that has never been my philosophy, ever. And technology, fortunately, has come along pretty well over the years. Early on, I used to do an old-fashioned technique where it would remove the lining of the uterus myself manually, and patients were very happy with that. It's an outpatient procedure that not many do anymore. But today we have techniques that are quite remarkable. We have ablation techniques. That's the new technology today. So when the women know that they have bleeding that is unacceptable to them, they're bleeding to their clothing, it's disrupting their daily lifestyle, they have horrible cramps or whatever it might be, this outpatient procedure takes 20 minutes. There's no cutting involved. There's a telescope that we use anymore for things like this. They go home the same day. They have maybe a day or two out of work, and they're back doing their normal. This is wonderful for patients that are in this particular category, that this treatment is the right one for them. Years ago, it was just hysterectomy. You were done with you're having heavy bleeding. Let's just get rid of that thing. But that's a major procedure. For some, it's an open abdominal procedure. For others, it's a laparoscopic procedure. But it's nice if you have no abdominal procedure and it could be done vaginally. And I do so many of these anymore. Women come into me with these abnormal bleeding problems. And once I prove that it's not anything serious, we can go ahead and have these ablation techniques done outpatient. And they're quite happy. There's over a 90% satisfaction.
Dr. Muir, with the ablation, is that something you can only get done one time, or is that something that a woman would, does it depend on the female, and can that bleeding come back?
That's a good question. The ablation techniques, even though they're very, very well received, they, after about 5, 6, 7 years, we're finding out that sometimes they get their menses back a little bit. But let me tell you what, it's a joke compared to where they were. They're usually very happy. The numbers are as follows. I tell patients about 40% will have no more menses, and they are thrilled with that concept. There's no hormonal manipulation involved. It basically, they're still cycle, they just don't have a menses each month. About 55% or so will have extremely light flow, barely worth a pad, but they're thrilled too because they were having bleeding problems that were awful and disrupting their life. And there's about a 5% failure rate, which means those are the ones that go on to hysterectomy if they want. But to answer your question, after 5, 6, or 7 years, they may have a return of a little bit of increased menses, but by then they're starting actually to approach menopause, a lot of them, and it's something that does not need additional procedure. I've been doing enough of them now over the years. I've had quite a few that the technique is pretty good. Patients are very happy. My hysterectomy rate after ablation is probably only about 8 or 9%, which is low, which is very low. But it's got to be done. It's got to be done. I've had a few patients where I've had to redo a few of the ablations, but it's single digits in the years of the practice.
So is it always a bad sign to have bleeding when you're postmenopausal?
Any and all bleeding after 1 year of no menses needs investigation. A decent percentage of them are malignant, and they have to have your workup to determine that. There are other reasons for having bleeding postmenopausal. There could be polyps are a big deal. The polyps are very common. There's hyperplasia, which is not actually cancer, but also causes bleeding. These patients oftentimes have multiple risk factors for these problems. Risk factors for endometrial cancer are obesity and not having children and diabetes and hypertension. So you can see that fits a lot of patients, but ultimately the cancer diagnosis needs to be ruled out before anything else could be addressed.
So if you are in menopause and you start bleeding, then there's a problem?
There is always something, there's a problem that needs to be investigated. It's not always a cancer.
Okay.
But and the further away you get from your last menses, the more likely it's going to be a cancer, and there needs to be a sense of urgency to get that worked out.
So don't ignore it, because some people, they
Never.
get scared. Oh my God, there's a problem. I'm not going
No.
to the doctor.
Here's what happens. They come in and by the time I see it, they're like, well, I started bleeding almost a year ago, but I have to wear a pad every day now, and it becomes an inconvenience. Well, that first bleeding episode they had a year ago was the shot across the bow that said there's something really wrong here. I don't care if it's a spot. I don't care if it's a little bit of pink that you see on the tissue. If you've already gone a year without menses, then you're in the menopausal range. That becomes postmenopausal bleeding, and all postmenopausal bleeding needs to be looked at for possible cancer as soon as you find the bleeding episode. Let me tell you something. When you wait on any cancer, it'll spread. So when you have an early signal from the uterus, uterus is a friendly organ, but it tells us early when there's something going on. So if you see any bleeding at that time, come in to be seen. And uterine cancer is not a death sentence for the vast majority of patients because they come in with that bleeding episode. Just make sure you make that appointment as soon as you see bleeding, or if you do see bleeding.
How important is it for a woman to continue going to see the gynecologist each year? And when should she stop going to the gynecologist, if at all?
Let's not forget, breast cancer is about 1 in 9 women. It's a very common cancer. Uterine cancer, 1 in 50 women. Ovarian cancer, 1 in 70 women. So it's not unseen. Also in the menopause, even when they get older, they get vulvar problems. They can have vulvar cancers. They need to be seen until about age 65, about once a year. They really need to be seen about once a year. After 65, we can space it out to every 2 years. And then once you get into the octogenarians, up in that range, maybe we could space it out a little bit more over 80. But you can never stop going. There's always stuff that can happen. I'm disappointed when I see patients that come in, they had problems for years, but they just don't want to go and be seen because they think, well, I'm done with my kids and I don't have to be seen. That is incorrect. They should still be seen about every year or 2 on a regular basis.
Hopefully, next time we have you on the show, it will be in person. We're hoping to do
we're looking
that.
forward to that.
But always a good time having you on the show. And fingers crossed, one day maybe you'll be delivering one of my kids' babies and my brother's babies long down the road. So
that would make me a great grandmother. Yay.
Oh my gosh, that's serious generational care is what that is. I'm looking forward to it. Thank you for having me on.
All right. Well, I heard the phone ring for you, Doc. I think you have a delivery, so we're going to let you go.
All right.
Thank you again. Time on the girls.